Okay, this is the MDC4 final exam Quizlet review. What does triaging do? It acts as a gatekeeper, helps prioritize patient care based on illness and severity level. According to triage, what patients would be seen first? Highest acuity patients will receive quickest intervention. Most ill, severe will get seen first. What is a good model for triaging patients? ABCs. Is hospital triaging the same as mass casualty triaging? No. Which triage situation uses tags? Mass casualties. What are the categories of triage? Emergent, urgent, non-urgent, primary survey. What classifies a patient as emergent according to triage? Life-threatening injuries and needs immediate treatment. What patient conditions warrant an emergent status of triage? Respiratory distress, chest pain with diaphoresis, stroke, active hemorrhage, unstable vitals. What classifies a patient as urgent according to triage? Patient should be treated quickly, but there is not an immediate threat to life. What patient conditions warrant an urgent status for triage? Severe abdominal pain, renal colic, displaced multiple fractures, new onset of respiratory infection like pneumonia. What classifies a patient as non-urgent according to triage? Patient can wait several hours without a risk to life. What patient conditions warrant a non-urgent status for triage? Skin rash, strains, sprains, colds, and simple fracture. What is the primary survey that should be performed while triaging? A, B, C, D, E. What does A, B, C, D, E stand for in triaging patients? Airway and cervical spine, breathing, circulation, disability, exposure. What does the A refer to in A, B, C, D, E? Airway, cervical spine, patent airway, immobilized spine. Do not move patient. What does B refer to? Breathing, assess sounds, assess chest wall movement. What does C refer to? Circulation. Vitals, blood pressure and pulse, maintain vascular access, and stop any bleeding. D is disability and level of consciousness. E is exposure, get clothes off, use blankets to prevent hypothermia. What is the one exception to A, B, C, D, E? In excessive bleeding, you prioritize C before A, B. What is the secondary survey? Comprehensive head-to-toe assessment. If warranted during the secondary survey, what would a nurse likely do? Insert NG tube, insert catheter, and prep for diagnostics. What does drowning lead to? It leads to loss of surfactant in lungs, which causes alveolar collapse and pulmonary edema. Is dehydration common in heat exhaustion? Yes. What can major diaphoresis cause? Severe dehydration and hyponatremia. If heat exhaustion goes untreated, what can it cause? A heat stroke. What are the signs and symptoms of heat exhaustion? Dehydration, decrease in blood volume, decrease in blood pressure, tachycardia. What is the first intervention for a person expected to have heat exhaustion? Stop their physical activity and transfer to a cool place. What is the quickest way to reduce someone's temperature? Remove clothing, remove bed linen. What interventions are there for cooling patients down? Cold pack on the neck, chest, abdomen, and groin. Soak in cool water. When rehydrating someone with heat exhaustion, should you use water or a sports drink oral rehydration solution? Sports drink and oral rehydration solution. Why is a sports drink better at rehydrating patients with heat exhaustion? Plain water can worsen sodium deficits. Nursing care for patients hospitalized with heat exhaustion. Monitor vitals, administer 0.9% normal saline, If nausea and vomiting is present, draw labs to check electrolytes. How is heat stroke defined? Body temperature greater than 104. True or false? Heat stroke is a medical emergency. True. True or false? If heat stroke is left untreated, it becomes fatal. True. Signs and symptoms of heat stroke: tachycardia, hallucinations, irregular pulse, decreased urine output, hot and dry skin. Nursing care for heat stroke: O2 and 0.9% normal saline via IV, continuous cooling, IV fluids, and cooling blankets. When should continuous cooling, IV fluids, and cooling blankets be stopped? When core temperature reaches 102. What should you do if your patient is shivering while being cooled from heat stroke? Administer benzos because they provide sedation. Control convulsions, and control shivering. What should you not administer for a person with a high body temperature? Aspirin and antipyretics. At what temperature does hypothermia occur? Less than 95. Nursing care for hypothermia: find shelter away from cold, remove wet clothing, monitor for cardio issues, ARDS, and pneumonia. Focus on rewarming slowly. In hypothermia, why should cardio issues be monitored? Dysrhythmias could result from lactic acid buildup. What is frostbite? Freezing of body tissue. How many degrees of frostbite are there? 4. What happens with first-degree frostbite? Hyperemia and edema. Hyperemia is increased blood flow. What happens with second-degree frostbite? Red area, blisters with clear, milky fluid, partial thickness, necrosis. What happens with third-degree frostbite? Small blisters with dark fluid, body is cold, numb, blue and red, and no blanching. What happens with fourth degree? No blisters or edema, numb, cold, bloodless, and in the muscle and bone. What happens when frostbite reaches the muscle and bone? Gangrene. This is a 4th degree frostbite. How is a person warmed after frostbite? Rapid rewarming with a water bath that's temperature is 104 to 108 degrees. How is a frostbite injury handled after rewarming has taken place? Injury should be handled above the heart level. Nursing care for frostbite: pain control with analgesics and IV rehydration, loose, non-adherent sterile dressings. What pain medication should be used for frostbite? IV opiates. True or false? For a person with frostbite, the nurse should tightly wrap the patient's wound. False. Compression should be avoided. What are arthropods? Spiders, scorpions, bees, and wasps. Nursing care for a patient injured by an arthropod: remove stinger, cold compress, EpiPen, and oxygen for anaphylaxis. What is affected by a lightning injury? Heart and CNS. Who is most at risk for a lightning injury? Young adult males. What nursing care is needed for a lightning injury? Immediate CPR, ECG, CT, and tetanus prophylaxis. What system is used during a mass casualty to sort patients into priority of care? A tag system. What information do you write on the triage tags? Color and priority, age and date of birth, these are identifying characteristics, treatment and meds already given, and next of kin. What is the color system for triage? Green, yellow, red, black. What does the color green mean in triage? Non-urgent, walking and talking. Yellow is urgent but not life-threatening. Red is emergent, could die if not treated, but have better odds. And black is do not attempt to treat them because their injuries are too extensive and will die regardless. Interventions to manage stress: develop a buddy system with a coworker, have well-balanced meals, drink a lot of water, take breaks, do not exceed more than 12 hours a day, stay in touch with friends and family, crisis debriefing, and take a few minutes each shift to decompress. MRC is the Medical Reserve Corps. Why is MRC a thing? Created for volunteers in the community who want to donate their time and expertise to prepare for and respond to emergencies on a local scale. DMAT, Disaster Medical Assistance Team. What does DMAT do? They are federal employees who make up medical relief team made of civilians whose license is valid in all states when working. How can a person be prepared for disasters? Have a go bag with personal readiness supplies, should be enough for 3 days at least. What is an internal disaster? Anything impacting inside the hospital. Examples of an internal disaster: fire, water pipe burst, power outage, shooting at Seattle Grace. What is an external disaster? A disaster that occurs in the community and may be natural, man-made, or terror-induced. Examples of an external disaster: earthquake, flood, car pileup, ferry boat crash. What is the most common type of dementia? Alzheimer's disease. Is Alzheimer's reversible? No. What is the etiology of Alzheimer's? It's unknown. Alzheimer's is the result of changes in personality, memory, and/or judgment. What are the risk factors for Alzheimer's? 65 and older, female, head injury, and APOE gene. What is the pathology of Alzheimer's? Plaques, tangles, degeneration of neurons. How is Alzheimer's diagnosed? Biopsy at autopsy is the only definitive way, but dementia can be ruled out with CT, labs, UA, and MRI. Early signs and symptoms of Alzheimer's disease: decreased short-term memory, decreased sense of smell, misplaced items. Middle signs and symptoms of Alzheimer's: wander, agitated, incontinent, and money issues. Late stage: bedridden, agnosia, which is inability to recognize objects, people, or sounds. Medications used for Alzheimer's: cholinesterase inhibitors, slow breakdown of ACH, donepezil and rivastigmine. NMDA receptor antagonist, block excess amounts of glutamate, memantine. Nursing care for Alzheimer's: safe environment, 1, good lighting, no clutter, stick with a routine, offer walks, exercise, reduce distractions, avoid use of restraints. What is Parkinson's disease? Movement disorder caused by the death of cells that generate dopamine in the basal ganglia and substantia nigra, both levels of dopamine and high levels of ACH. How does Parkinson's progress? Slowly, but will eventually lead to disability. How is Parkinson's diagnosed? History and signs and symptoms. Signs and symptoms of Parkinson's: tremors, muscle rigidity, mask-like facial expression, bradykinesia, shuffling gait, cogwheel rigidity in limbs, propulsive gait, which is head and neck forward, back is slouched. Nursing care for Parkinson's: safe environment, sit up when eating, thick liquids, encourage range of motion and exercise. Medication for Parkinson's: Sinemet, levodopa, increases dopamine levels in CNS, and carbidopa prevents levodopa breakdown. Take it same time every day. Know that increased protein can alter effectiveness. Benztropine decreases ACH levels. What are headaches? Vasodilation of blood vessels in the brain. What causes headaches? Genetics, stress, and hormones. What can trigger a headache? Coffee, yogurt, alcohol, MSG, and marinated foods. Signs and symptoms of a headache: head pain for 4 to 72 hours, nausea or vomiting, unilateral pain, may come with an aura. What are cluster headaches? They happen at night and stuffy nose. Treatment of a headache: prophylactic equals propanolol, mild is an NSAID, severe is sumatriptan. Ergotamine tartrate, 6 tabs in 1 day, take as soon as pain starts. MOA equals constricts cerebral blood vessels. What is increased ICP made of? CSF, blood, and brain. What causes increased intracranial pressure? Infection, trauma, increased CSF, hemorrhage, and tumors. Signs and symptoms of increased ICP: think mind crush, M, mental status change. Early sign equals decreased level of consciousness, irritable and confusion. I, irregular breathing. Late sign, Cheyne-Stokes. N, nerve damage to eye, pupil changes. D, decerebrate, limbs out, and decorticate, limbs to core, posturing. C, Cushing's triad, late equals hypertension plus Brady plus wide pulse pressure. R is reflux, nausea, and vomiting. U, unconscious. S, seizures. H, headaches, mind crush. Nursing care for increased ICP, think press. P, position head of bed at 30 degrees and make sure body's midline, no flexion of the neck or hips. R, respiratory, we want to prevent hypercapnia by hyperventilating, limiting suctioning. E is elevated temp, prevent it. S is system checks equals neuro checks. And the other S is straining things, avoid it, no lifting, blowing nose, coughing, or sneezing. Press. Additional nursing care measures for ICP. Turn down the lights, no TV or noise, put sign on door telling visitors to see the nurse first. What do you not do when someone has increased ICP? A lumbar puncture. What is the Glasgow Coma Scale? A brain injury severity scale that assesses depth and duration of impaired consciousness and coma. What 3 areas make up the Glasgow Coma Scale? Eyes score, 1 to 4. Verbal score, 1 to 5. Motor score, 1 to 6. Total score is 3 to 15. Lower the score equals more severe injury status. Eyes for Glasgow Coma Scale. Think ESPN. Eyes open spontaneously, that's 4. Sound is 3. Pain is 2, and N is not open, that's 1. Verbal for Glasgow Coma Scale, our country win. Oriented, confusion, words are inappropriate. OCW. Incomprehensible sounds and nothing. IN. Okay, motor for Glasgow Coma Scale. Can't live without fans. So commands followed are 6. Localized to pain is 5. Withdrawal from pain is 4. Flexion, decorticate posturing is 3. Abnormal extension is decerebrate, that's 2. And nothing is 1. What are seizures? Abnormal and increase in firing of neurons. What is epilepsy? Chronic seizures. What triggers seizures? Stress, fatigue, coffee. What are risk factors for seizures? Infection, trauma, fever, withdrawal, imbalances. How do you diagnose a seizure? EEG, wash hair prior. Seizure precautions, padded bed rails, O2 and suction at bedside, IV access, and lowest bed setting. Type of seizures, absence, atonic, tonic-clonic, and status epilepticus. Absent seizures is daydreaming, level of conscious for a few seconds. Signs and symptoms is pick at close, lip smack, and blank stare. Atonic seizures is loss of muscle tone and fall. Tonic-clonic seizure, tonic is stiffening, clonic is rhythmic jerking. Post-ictal phase is coming back to, and they're confused and sleepy. Status epilepticus is a medical emergency. 1 seizure that lasts more than 5 minutes and repeat of seizures within 30 minutes. Nursing care during a seizure. Turn patient on the left side. This is number 1. Loosen restrictive clothing. Note onset and duration, and do not insert anything by mouth. Nursing care after seizure. Take vitals. Perform neurochecks. Determine what trigger was. Maintain left lying position. Treatment for seizures. Phenytoin. This is for narrow range. It's 10 to 20. Signs and symptoms is gingival hyperplasia. Valproic acid. Signs and symptoms is hepatotoxic. And carbamazepine can cause a rash. Stevens-Johnson syndrome. Education for seizures and seizure treatment. Medication compliance. Abrupt withdrawal equals rebound seizure. Do not drive. Wear medical alert bracelet. Surgical treatment of seizure. Vagal nerve stimulator and craniotomy. What is encephalitis? Infection and inflammation of the brain tissue. This is life-threatening. How is encephalitis diagnosed? CSF analysis or EEG. What are the signs and symptoms of encephalitis? Stiff neck, nausea, vomiting, and fever. What can encephalitis increase risk of? Increased ICP. Nursing care for encephalitis. Turn down lights and noise. Keep midline and head of bed at 30 degrees. Avoid straining activities. What is meningitis? Inflammation of meninges around the brain and spinal cord. What are the two main types of meningitis? Viral is more common. Bacterial causes is strep. Prevention of meningitis. Vaccination. HIB for baby. MDC4 for teens. Diagnosis of meningitis. CSF analysis. What does CSF analysis look like for viral meningitis? Clear, increased white blood cells, and protein. What does CSF analysis look like for bacterial meningitis? Cloudy, decreased glucose, increased white blood cells, and protein. Signs and symptoms of meningitis. Nuchal rigidity, nausea, vomiting, photophobia, Brudzinski sign, and Koenig sign. What is Brudzinski sign? After forced flexion of the neck, there is a reflex flexion of the hip and knee and abduction of the leg. What is Koenig sign? After flexing the hip and knee at 90-degree angles, pain and resistance are noted. Nursing care for meningitis. Bacterial equals antibiotics. Viral equals acyclovir. Steroids decrease inflammation, increase infection. Prophylaxis treatment for anyone in contact or exposed. Implement droplet precautions for first 24 hours of treatment. Decrease ICP risk by elevating the head of bed. Keep body midline. Avoid straining activities and turn everything down. What is MS? Autoimmune disease with chronic inflammation and no cure. Just periods of relapse and remission. What is the pathophysiology of MS? Body attacking its own myelin sheath. What causes MS? Genetic autoimmune infection. What are risk factors for MS? Female, white, and 20 to 50 years old. Diagnosis of MS. There's no 100% way, but they'll do an MRI and a CSF analysis, which will show increased white blood cells, proteins, and IgG. Signs and symptoms of MS. Muscle weakness, intention tremors, tinnitus, vision, which is diplopia, and nystagmus. Nursing care for MS. Protect from injury, allow for periods of rest, help manage stress because this can lead to relapse. Meds for MS. Immunomodulators and immunosuppressants. Decreased inflammation and increased infection. Muscle relaxant is baclofen. What is autonomic dysreflexia? This is firing of the SNS with no PNS response. What injury causes autonomic dysreflexia? Injury above T6. What causes autonomic dysreflexia? Bowel, bladder, breakdown of skin. Signs and symptoms of autonomic dysreflexia. Severe hypertension, bradycardia, headache, diaphoresis, blurry vision, facial flush above the injury, and pale below injury. Nursing care for autonomic dysreflexia. Prevention is bladder distension, empty it, checking tubing for kinks, and use a bladder scanner. Bowel is check for impaction and skin breakdown, remove tight clothing. Detection is at risk above T6 injury, report of headache, check blood pressure. And action is elevate head of bed, remove restrictive clothing, schedule bowel and bladder maintenance. What is true for spinal cord injury? The higher the injury, the more system affected and shorter the lifespan. Diagnosis of spinal cord injury. X-ray, CT scan, and MRI. Prevention of spinal cord injury. Stop drugs and alcohol. Causes of spinal cord injury. Traumatic is falls, motor vehicle accident, and violence. Non-traumatic is tumors and rheumatoid arthritis. Direct is fracture, hyperflexia like diving, hyperextension penetration like GSW, and axial load. Types of spinal cord injuries. Complete is complete severed spinal cord, complete loss of function below the injury. Incomplete is the spinal cord is partially severed, partial loss of function. Quadriplegia is at C6, unable to move all four extremities, and MVA, this is from an MVA or a fall, motor vehicle accident or a fall. Paraplegia is below T1. This is paralysis of lower extremities, can be as a result of GSW. What is the main cause of death for people with spinal cord injuries? Sepsis, pneumonia, and PE. Acute management of spinal cord injury. Airway and breathing, immobilize head and neck with a C-collar, and determine level of consciousness by using GCS. Medications for spinal cord injuries. Corticosteroids equal methylprednisolone, first given as an IV bolus, then IV continuous drip for 24 hours. It needs to be given within 8 hours of the injury. Signs and symptoms is hyperglycemia, poor wound healing, infection, and the education is increased calcium intake, range of motion, and deep breathing. What is the number one thing to keep in mind with a spinal cord injury? Airway and breathing. Complications of a spinal cord injury. Autonomic dysreflexia and neurogenic shock. Hypo, Brady, edema, and temp. What is a stroke? Alteration in blood flow to the brain. TIA, transient ischemic attack. This is a mini stroke and it's a warning sign. Diagnosis of a stroke. CT without contrast. Etiology of a stroke. Non-modifiable is age, sex, and history. Modifiable is hypertension, BC user, high cholesterol, and smoker. Signs and symptoms of a stroke. Fast. Think fast. Facial droop, arm drift, speech is slurred. Time. How much has passed? General left versus right side stroke. Left is language, right is impulse and judgment. Left-sided stroke, signs and symptoms. Receptive aphasia, unable to verbally communicate back. Right-sided is hemiparesis, weakness. Agraphia, which is unable to write. Aware of their deficits like anxiety and depression. Right-sided stroke is poor impulse control and judgment. One-sided neglect syndrome, which they're unaware of deficits on the left side of the body. It's a big safety concern. A shortest attention span, and proprioception which is depth issues. Broca's area, expressive aphasia, which means they're unable to communicate and express back in speech. Wernicke's aphasia, receptive aphasia, which means they're unable to receive or understand what is being said. Nursing care for both Broca's and Wernicke's is be patient, use short phrases, use gestures and point, and limit distractions around. Treatment of a stroke. General, this is anticoagulants, stool softeners, and benzos. Ischemic stroke, also known as a clot, give TPA. Thrombolytics must be within 3 hours. BP needs to be in range. Neuro checks every 15 minutes, not for bleeding, hypertension, and greater than 3 hours. Hemorrhagic stroke is only treatment is surgery. BP must be in range, not for someone on blood thinners such as Coumadin. If blood is too thin, administer fresh frozen plasma or vitamin K. Nursing care for stroke. Safe environment. Teach patient to scan before ambulating. Lots of eating concerns. Sit up, tuck chin, thick liquids, use dentures, no straws, take small bites, and use mechanical soft diet. Complications of a stroke is increased ICP, seizures, hypertension, and headache. Who is at risk for TBI? Infants, teens, and older adults. How does TBI occur? Falls, motor vehicle accident, GSW, and sports. Levels of TBI. Mild is concussion. Moderate is decreased level of consciousness. Severe is prolonged level of consciousness. Types of TBI. Subdural hematoma, bleeding below dura and above arachnoid. Primary is open directly to the brain, closed fracture. Secondary is result of primary. Nursing care for TBI. Number 1 is determine what caused the injury. Monitor level of consciousness by GCS. Watch for CSF. Clear drainage shows halo with test. Wiping is okay. Blowing and inserting is no. Prevent increased intracranial pressure. Complications of ICP. Hydrocephalus, infection, stroke, increased ICP. Meds for ICP. Anti-seizure, mannitol, and corticosteroids. What are the assessment findings in pneumothorax? Sudden dyspnea, chest pain, feeling of doom and anxiety, JVD, tachy, chest petechiae, ECG changes, and abnormal heart sounds. What are the signs and symptoms of flail chest? Paradoxical chest movement, dyspnea, cyanosis, tachycardia, and hypotension. How does the patient usually present with flail chest? Anxious, short of breath, and pain. What are interventions for flail chest? Humidified oxygen, pain management, promotion of lung expansion through deep breathing and positioning, secretion clearance by coughing and tracheal suction. Can a person with flail chest recover? It's manageable with vigilant respiratory care. When is mechanical ventilation needed for a patient with flail chest? Respiratory failure, shock and severe hypoxemia, and hypercarbia. Nursing care for flail chest. Monitor ABGs and monitor vitals. With flail chest, what causes increase the risk of respiratory failure? Lung contusion and underlying pulmonary disease. How is flail chest usually stabilized? Positive pressure ventilation. What interventions are needed for low blood pressure? Fluid replacement, Trendelenburg position, compression stockings, and medication. What causes a high-pressure vent alarm? Thick mucus secretions blocking the airway, coughing, biting on tube, fighting vent, wheezing, bronchospasms, pneumothorax, and displaced tube. Obstruction, water and vent circuit. What causes a low-pressure vent alarm? Leak in circuit, cuff leak, patient disconnected, apnea alarm. Possible intervention for high-pressure vent alarm. Check the patient first. Check all tubing is connected and not kinked. Suction the patient. Medication for pain, anxiety, and sedation. Change the vent settings. What causes increased or thick secretions or mucus in a patient who is intubated? Not enough humidity. Possible interventions for low-pressure vent alarms. Check the patient first. Manually bag patient, reconnect and unkink tubing. Nursing care of ventilated patient. Q2-4 respiratory assessment, oral care and suctioning if needed. Q4 head-to-toe assessment and vitals. Maintain head of bed at 30 degrees. Q2 turns, monitor INO, collaborate with RT, monitor vent settings Q8 to 12. Manual resuscitation bag at bedside. Vent settings, tidal volume, rate, FiO2, O2%, size, and PEEP. What does tidal volume mean on a vent? Amount of air delivered with each machine breath. What does the rate mean on a vent? Number of breaths delivered by the machine in a minute. What does FiO2 mean on a vent? Fraction of inspired O2 written as 0.6. What does PEEP mean? Positive end expiratory pressure during mechanical ventilation. PEEP aids in preventing alveolar and small airway collapse and may help recruit lungs unit that were previously collapsed. What does size mean on a vent? Deep breaths, which is higher volume, delivered periodically by the vent. What does an FiO2 of 0.6 mean? 60% of oxygen. Acronym for vent alarms. HOLD. High pressure alarm equals obstruction. Low pressure alarm equals disconnection. What interventions help prevent ventilator-acquired pneumonia, or VAP? Head of bed at 30 degrees helps to prevent aspiration. Oral care, Q2 to 4, Q2 turns, and ulcer prophylaxis is famotidine and Pepcid. What does ARDS stand for? Acute Respiratory Distress Syndrome. What intervention is done for a healthy person who sustains an acute lung injury? Mechanical ventilation. Pathophysiology of ARDS. Increased alveolar permeability plus leaking fluid equals alveolar collapse. What causes ARDS? Sepsis, burns, pancreatitis, transfusion, trauma, diffuse pulmonary infection, gastric aspiration, O2 toxicity, and lung contusion. Signs and symptoms of ARDS: persistent hypoxia, even with O2 therapy, dyspnea, decreased pulmonary compliance, non-cardiac pulmonary edema. How to diagnose ARDS: refractory hypoxia, chest x-ray shows glossy and whiteout, diffuse patchy infiltrates, normal wedge pressure, the O2 and FiO2 is less than 200. Phases of ARDS: injury is exudative phase, alveolar collapse, refractory hypoxemia, reparative is the proliferative phase, decreased lung compliance, fibric phase is surfactant cells are damaged. Assessment of patient on vent: vitals, O2 saturation, auscultate breath sounds, pain and anxiety, tube placement, and vent settings. Nursing care for ARDS: ET plus mechanical vent with PEEP or CPAP, light IV fluids, diuretics, and antibiotics, start nutrition, TPN or tube feeds. Risk factors for pulmonary embolism, or PE: immobile, obese, advanced age, surgery, central venous catheter, embolic event history, pregnancy, oral contraceptives, estrogen therapy, heart failure, trauma, and a smoker. Assessment findings for PE: sudden dyspnea, chest pain, feeling of impending doom, JVD, tachy, chest petechiae, ECG changes, and abnormal heart sounds. Normal INR range is 0.8 to 1.2. Normal INR range while on warfarin for PE is 2 to 3. Normal PT range is 11 to 12.5 seconds. Normal PT range while on warfarin for PE is 1.5 to 2 times base, so 22 to 25. A normal range for APTT is 20 to 30 seconds. Normal range for an APTT while on warfarin for a PE is 1.5 to 2 times base, so 40 to 75. Normal range for platelets is 150,000 to 400,000. How to diagnose a PE: CT angiography, CT with contrast, VQ scan. V is airflow in lungs, Q is blood flow in lungs, and D-dimer can rule out PE but not diagnose. What to do if PE dislodges: place patient in left-lying Trendelenburg position, O2 therapy, and call RRT. Interventions for PE: continuous pulse ox, hypotensive, give fluids, patient education, stop smoking, lose weight, increase fluids, and increase movement. Medication treatment for PE: anticoagulants, initiate bleeding precautions, heparin, watch APTT and platelet count, warfarin, watch PT and INR levels. Antidote is vitamin K. Fibrinolytic is thrombolytic alteplase or TPA. Surgical treatment for PE: embolectomy, which is a removal of the clot. Inferior vena cava filter, which is a temporary filter that keeps clots from getting to lungs, and that's not for patients on heparin. Hypovolemic shock assessment findings: weak thready pulse, tachy and hypo, cold clammy skin, and decreased CO, carbon dioxide, equals decreased tissue perfusion. What is neurogenic shock? It's caused by spinal cord injury, usually as a result of a traumatic accident or injury. It's common with T6 and up, and in the SNS disruption. Neurogenic shock assessment findings: hypotensive and bradycardic, warm and dry skin, and hypothermia. Neurogenic shock treatment: establish circulatory blood volume, administer atropine for low heart rate, keep patient warm, prep to intubate. What is DIC? Disseminated intravascular coagulation. What does DIC cause? Abnormal coagulation involving fibrinogen, excessive clotting, along with hemorrhage at the same time. Treatment of DIC: blood transfusion, fresh frozen plasma, and fluid replacement. Lab values for lactate during hypovolemic shock: greater than 2 indicates shock. Medication for hypovolemic shock: vasopressors. What do vasopressors do? They increase the workload of the heart. What does vasopressin do? Causes vasoconstriction, which increases the blood pressure, reabsorption of water in the renal tubes, and increases blood flow to the heart and brain. Interventions of burns: secure airway, support circulation, this is with fluid replacement, prevent infection, maintain body temperature, and provide emotional support. What causes dry heat burns? Open flames. What causes moist heat burns? Hot liquids. What causes contact burns? Hot metal, tar, or grease. What causes chemical burns? Alkali, acids, organic compounds. Alkali burns are worse than acid burns. What causes electrical burns? Electrical current enters the body. What causes radiation burns? Sunburns or radiation treatment for cancer. Rule of nines for burns: head is 9%, arms is 18 or 9% each, back is 18, front chest is 18, legs is 36 or 18% each, genitalia is 1. What is an escharotomy? Incision through eschar relieves pressure from constricting force of fluid buildup under circumferential burns on the extremity or chest and improves circulation. Inhalation injury assessment: face or neck burns, singed nasal hairs, soot and upper airway, assess sputum. With a superficial or first-degree burn, what layer of skin is affected? The epidermis. With a partial thickness or second-degree burn, what layer of skin is affected? Epidermis, partial dermis, and hair follicles intact. With a full thickness, third-degree burn, what layer of skin is affected? Epidermis, dermis, SQ, and possible muscle and bone. What is usually the cause of a superficial first-degree burn? Sunburn, UV light, and flash injuries. What is usually the cause of a partial thickness, second-degree burn? Contact, flash flame to close, direct flame, chemicals, and UVL. What is usually the cause of a full thickness, third-degree burn? Contact, flame, chemicals, and electrical. What is the appearance of a superficial first-degree burn? Dry, no blisters, minimal edema, and blanches. What is the appearance of a second-degree partial thickness burn? Blisters, superficial, moist blanches. Deep is less moist and decreased blanching. What is the appearance of a full thickness third-degree burn? Dry with leathery eschar, charred vessels, and no blanching. What is the color of a superficial first-degree burn? Red. What is the color of a partial thickness second-degree burn? Superficial is pink, and deep is pale mottled with dull white, tan, and cherry red areas. What is the color of a full-thickness third-degree burn? White, charred, dark tan, black, and red. What is the sensation of a superficial first-degree burn? Painful. What is the sensation of a partial thickness second-degree burn? Painful. What is the sensation of a full thickness third-degree burn? No pain. What is the healing time for a superficial first-degree burn? 2 to 5 days, usually dry and peeling. What is the healing time for a partial thickness second-degree burn? Superficial is 5 to 21 days, and deep is 22 to 35 days. What is the healing time for a full thickness third-degree burn? No healing potential. What are treatment interventions for a superficial first-degree burn? Mild analgesia. What are the treatment interventions for a partial thickness second-degree burn? Deep burns may require grafting. What are the treatment interventions for a full thickness third-degree burn? Excision and grafting and amputation. Parkland formula for burns: 4 milliliters times kilograms times the percent of burn surface area. Give half fluids in the first 8 hours and remaining half in the last 16 hours. What fluid is given for burns? Lactated ringer or normal saline? How to calculate MAP? SBP plus 2DBP divided by 3. What labs are used to measure nutrition after burns? Albumin, prealbumin, total protein. What are the different types of shock? Cardiogenic, hypovolemic, anaphylactic, septic, and neurogenic. What is cardiogenic shock due to? Heart problems. What is hypovolemic shock caused by? Too little blood volume. What is anaphylactic shock caused by? Allergic reaction. What is septic shock due to? Infection. What is neurogenic shock caused by? Damage to the nervous system. When do we consider a patient a candidate for trach placement after ET intubation? Patient with respiratory failure who cannot be weaned within 7 to 10 days are candidates for tracheostomy. Most severely injured trauma patients requiring intubation longer than 5 days will require airway support and will benefit from early tracheostomy. I would have to tell you guys that I'm so proud of you and congratulations on finishing your final exam and final semester with nursing school. I wish you all the best of luck, and I hope that you all message me and tell me the jobs that you've gotten, because I'm so excited to hear all of your success stories, and I'm excited to see where everyone goes. So thank you so much, and keep sharing my YouTube channel because it helps a lot of people, and I'm so thankful of that because I think it's super awesome.